And with that, I'd like to introduce Dr. Amre, who came to us at McGill via pathology training at St. Luke's Roosevelt, the hospital in New York, and then a fellowship in Beth Israel in Boston. And she will discuss the staging systems of neuroendocrine tumors. Dr. Amre?
Okay, thank you very much, Dr. Metragas, for the introduction, and welcome everybody. So today I'm going to talk about the staging system for neuroendocrine tumors, specifically of the gastroenteropancreatic tract, and the importance of a well-reported biopsy, some of the points already touched upon by Dr. Rivera. So the points to be included in a report, in a biopsy report of a neuroendocrine tumor, are the very minimum, the grade of the tumor, that is the degree of differentiation, which is a morphological assessment that we do under the microscope. That is to see if the cells are well differentiated or poorly differentiated. So that's really only two categories that you can put it into. It's well differentiated or poorly differentiated tumors. The second thing would be the presence of vascular invasion or perineural invasion, if that is present. Usually the vessels that we see that have invasion are the smaller thin wall vessels like the veins or the lymphatics. So these are the vessels that we are usually evaluating. And then the other thing you would have to mention is the mitotic count, which we assess in 10 high-power fields. So it's recommended that a minimum of 40 to 50 high-power fields are reviewed on the slide, and then come to an estimate approximately as to what the mitotic count is per 10 high-power fields. And the prognostic significance is that if it's less than 2 per 10 high-power fields, it's a pretty well-differentiated, usually goes with the well-differentiated tumors, and the more poorly differentiated tumors have pretty high mitotic counts, often more than 10 in 10 high-power fields. And then there are tumors that fall in between category between 2 to 10 mitotic figures in 10 high-power fields, which behave in a slightly aggressive fashion, but then it's not as malignant or as high-grade malignant as the poorly differentiated tumors. And then we do an immunostain that is called Ki-67. This is a proliferation marker. So it's essentially telling us what the proliferation rate of that tumor is. And the well-differentiated tumors typically have a proliferation rate that's lesser than 2%. Again, it's recommended to count the Ki-67 within at least 2,000 cells, 2,000 tumor cells, and then come to a conclusion as to the percentage. And this is often found to be higher near the edges of the tumor, so we tend to focus more at the periphery of the tumor. And then lastly, if it's an excisional biopsy, this is something I added later, that it's a biopsy sometimes that we see in which the tumor is relatively small, and so the surgeon attempts to enucleate it, so to speak, and so he does an excisional biopsy. So in that case, we mentioned the microscopic size. These are usually pretty small tumors, like I said, so they are probably a centimeter or less. And then we also evaluate the margins and say whether the margins of the excision are free of tumor or if there is any tumor at the margins. And in the gastric tract, the margins are typically the serosal surface of the biopsy, and also the lateral edges. So if there is any extension to one of the lateral edges, it would mean that there is some tumor still left behind, so we would mention that. Oh, I'm going back. So when I was preparing for this conference, I was asked to talk about the ENETS classification for the gastroenteropancreatic tumors, so the foregut, midgut, and hindgut tumors. And so most of my slides have that information. But then just in the few days before this conference, the College of American Pathologists, which puts forth the TNM staging for all the tumors in the body, has proposed the TNM staging actually for all the gastroenteropancreatic and lung neuroendocrine tumors. So this is really new information. It's just something in the last few days. So I've added a few slides about that also. In North America, typically people would use the CAP protocol, and that is what is practiced here. But I have included the ENETS here. So it is basically the ENETS proposes that you grade them as G1, G2, and G3. And this depends on the mitotic count and the Ki67 index. That is, the G1 tumors, the well-differentiated ones, have less than 2 mitosis per 10 high-power fields, and the Ki67 can be up to 2%. The G2s have between 2 to 20 mitosis, and the Ki67 is between 3 to 20%. And the G3, which are the poorly differentiated ones, have very high mitotic counts, more than 20 per 10 high-power fields, and more than 20% Ki67. So just to give you an idea what we're talking about, this is what a biopsy looks like, and it's really hard to look at it from this angle, but I cannot do this without pointing at it. I don't know if you can hear me. Absolutely. Okay, good. So this is a rectal biopsy. We have the surface mucosa here, and the tumor is in the submucosa. If you can hear me, it's okay. So the tumor is right here in the submucosa, and anyway, the tumor is composed of, you see these glandular or pseudoglandular arrangement of very monomorphous looking cells. That means they resemble each other. And thank you. And the Ki67, which is a nuclear stain, and we see that here, is a dark brown staining. That is the positive staining. And so we see that the Ki67 is positive in a few of the cells, but the count was really less than 2% overall in the whole tumor. And this is synaptophysin. This is a neuroendocrine marker that Dr. Rivera just mentioned that stains the cytoplasm. And so you see the brown staining in the cytoplasm, and that is strongly positive. So this was an example of a rectal biopsy which had a well-differentiated neuroendocrine tumor. There was no discernible mitosis really, so we couldn't really find any. And the Ki67 was low, it was less than 2%. Bear in mind that some of the cells that you see staining are not tumor cells, like that one there is a lymphocyte. The tumor cells are here. So you have to be sure that the cells that you're looking at are the tumor cells, because the lymphocyte staining or the endothelial cell staining with Ki67 doesn't count. Okay, so that, as I mentioned, was a well-differentiated neuroendocrine tumor or a carcinoid of the rectum. I just want to say a word going back to the term carcinoid. It's really encouraged that it no longer be used, because it seems to connote that the tumor is very benign and it doesn't have any potential to be invasive. So it's really encouraged to keep the term as well-differentiated neuroendocrine tumor or well-differentiated neuroendocrine carcinoma when there's an obvious invasion or metastasis in the body. This is a duodenal excisional biopsy, and again, I have to come across. So what we have here are, okay, the pointer seems to have given up on me. So much. So this is a duodenal biopsy where we have the mucosal surface here at the bottom and the Brunner's glands in the submucosa there. And there are nests of these tumor cells which are seen to be infiltrating into the muscle layer. This is the pink tissue that you see is the muscularis. So you have the tumor cells infiltrating in pretty much solid sheets, and it's a different pattern architecturally from the earlier case. On a higher power, the neuroendocrine cells can have a plasmacytoid look to them, which means the nucleus looks eccentric and the cytoplasm is on one side. So this is very characteristic of some neuroendocrine tumors, and it's known. And the cytoplasm typically has a very eosinophilic granular appearance, which is because it contains all these neurosecretory granules. So this is one of the appearances that you see. And just to be sure that it's not a plasma cell tumor that we're dealing with, a cytokeratin stain would help you confirm that. And it stains the cytoplasm and the membranes of these tumor cells strongly positive. So we know we're dealing with a carcinoma, carcinoid kind of tumor. Sorry. And the synaptophysin tells you that it's a neuroendocrine tumor. It's again strongly positive. And finally, the Ki67, which is the proliferation rate, and that is pretty low. And you see there's one nucleus really staining strongly there, but most of the other cells here, at least, they're not staining. So it was less than 2% in this tumor also. Okay, so to talk about the WHO classification of gastroenteropancreatic neuroendocrine tumors, there are basically three categories. You can have well-differentiated neuroendocrine tumors, well-differentiated neuroendocrine carcinomas, and poorly differentiated neuroendocrine carcinomas. And this is based on the invasive capacity of that tumor, the size, and the mitotic rate. Okay. The well-differentiated endocrine tumors are, again, of two types. So those which are truly benign, and these are usually less than 2 centimeters in size. They don't show any angioinvasion. They show no perineural invasion. The Ki67 is low, less than 2%. And the uncertain behavior is a category for tumors in which we see either they are larger than 2 centimeters in size, or there is some vascular invasion that is picked up, or perineural invasion. So one of the criteria doesn't fit, so then it becomes the uncertain behavior, or the unknown malignant potential, as some people like to call it. The well-differentiated endocrine carcinomas are the ones which have an obvious gross invasion or metastasis in the body, and they histologically look identical to the well-differentiated endocrine tumors. The poorly differentiated endocrine carcinomas are a separate category altogether. They are much rarer, but the cells look very different, and I will show you some images of that. So just moving quickly along. This is a liver biopsy that shows a metastatic neuroendocrine carcinoma, and here we have the normal hepatocytes of the liver, and this is the tumor that is seen. And again, it has a very typical organoid or nesting arrangement that's very characteristic of neuroendocrine tumors. So the cells seem to be clustering like this, and in between you have a kind of vascular stroma separating these islands of tumor cells. And on a higher power, so we see these cells very clearly. Again, they're very monomorphous, very uniform looking. They really don't have very prominent mitotic activity or anything, but for sure this was an endocrine carcinoma, a well-differentiated endocrine carcinoma which was metastasizing to the liver. And the synaptophysin was strongly positive. So these are the proposed TNM stagings of the gastric endocrine tumors by the ENETS, the European Neuroendocrine Tumor Society. But this is in your brochure, so I will not, in the interest of time, go into it at the moment. The well-differentiated neuroendocrine tumors can also arise from the ampulla of Varer in the duodenum, and this is an example of a case where you see the tumor in the submucosa, and the surface mucosa looks normal. And this is a very well-differentiated tumor. So again, the cells look very monomorphous. They have quite a bit of cytoplasm, and the nuclei are small. This is a proposed TNM staging for endocrine tumors of the pancreas. Again, it's in your brochure. And this is an example of a case that was a well-differentiated neuroendocrine carcinoma of the pancreas. And you see the tumor. So the tumor is here, and this is the normal acini of the pancreas, which have this pink appearance, quite dark pink or bright pink appearance. And here you have some residual islets, and then you see the tumor here arising in this area. And this is a higher power view of the tumor cells, really monomorphous looking, bland looking, but it was indeed a neuroendocrine carcinoma of the pancreas. There were lymph node metastasis. So this is the new information. This is the proposal by the American Joint Commission on Cancer for the staging of neuroendocrine tumors that's just come up in the last few days. And they propose that the carcinoids, or the well-differentiated neuroendocrine tumors of the GI tract, be staged separately by the site, and I will go into that now. And the small cell and the large cell, the poorly differentiated neuroendocrine carcinomas, be staged as carcinomas of that site. So if it's a colonic small cell carcinoma, it should be staged as a colonic adenocarcinoma, so to speak. So the same TNM staging as that. that. A pancreatic endocrine tumor should be staged as a pancreatic carcinoma, and a lung endocrine tumor should be staged as a lung carcinoma. So this is the CAP approved protocol that has just come into play and is going to be implemented from January 2010, so in a month and a half from now. And so this is how they propose that the pancreatic tumors be staged. The carcinoids of the gastrointestinal tract have to be staged in this fashion. So the appendiceal tumors, the T1 is when it's less than 2 centimeters, T2 is when it's between 2 to 4 centimeters or involves the cecum, T3 is when it's more than 4 centimeters and involves the ileum, T4 is always the same for all GI tract, which is involvement of the serosa or involvement of the adjacent organs or structures. Well-differentiated neuroendocrine carcinoma of the colon. So we see the mucosa on the right side, and the tumor is arising from the base of the mucosa going down and infiltrating the wall. And on a higher part, we see that the subserosal tissues, which is the blood vessels, at the very end there, it's reaching into the subserosa. So if we were to classify it in today's age or from January, this would be a T3 tumor because it's going into the subserosa. And the Ki-67 was surprisingly low, so it was about 3% in this tumor. And this is a proposed staging by the ENETs for the lower jejunum and ileal tumors. Proposed classification of the endocrine tumors. These were proposed in 2005, and so this was information that I've already put in. But like I said, the CAP and the AJCC TNM staging is what we're going to be following from January. The proposed classification of TNM tumors of the colon and the rectum. There's not that much difference in the TNM staging of the ENETs and of the CAP. So you will find minor differences, but it's essentially pretty similar. So it's not a big difference there. And finally, just to show you an example of a poorly differentiated tumor. So this is a very different lesion from the cases that we saw before. As you can see, the cells look very high-grade malignant, and they're very high NC ratio, nuclear cytoplasmic ratio, which means you don't see much of that eosinophilic pink granular cytoplasm that you see with the well-differentiated tumors. There's basically these very atypical-looking nuclei. In terms of nuclear atypia, the well-differentiated tumors can show nuclear atypia that does not have a prognostic significance. But when you see a tumor that shows this kind of an architectural pattern, just solid sheets, presence of necrosis, very high-grade looking nuclei with almost no cytoplasm, along with that, you will expect to find a very high mitotic count. It's often more than 10 per 10 high-power fields, and the Ki-67 is also proportionately higher. And in this case, we see that the surface colonic mucosa is here, and this is the muscularis, the muscle layer of the colon, and the tumor is infiltrating into the muscularis. So it's at least a T2. And there is some vascular invasion. This looks like a vessel, a large vein probably. So there seems to be a vascular invasion too. So this was a poorly differentiated neuroendocrine carcinoma, and so this is a high-grade tumor of the colon. And the synaptophysin was again positive. So even the poorly differentiated tumors, I'd like to mention, retain the synaptophysin staining typically, though they lose the chromogranin staining. But the synaptophysin is positive, as we can see. This is an example of a well-differentiated neuroendocrine carcinoma with perineural invasion. So we see a nerve there, and the tumor has perineural invasion. The Ki-67 not very high. I think in this case it was about 2 to 3%. But there were lymph node metastases also. So it was clearly a carcinoma. It was a well-differentiated neuroendocrine carcinoma of the colon. Okay. So these are the references that I had used, and I don't know if you have questions or we do it later. Okay. Okay.